So for our next talk, we're going to have a discussion with regards to updates in drug-induced liver injury. I know everybody is familiar with Tylenol toxicity, but nowadays with the prevalence of immune checkpoint inhibitors, there's a variety of new liver injuries which we are seeing and for which we are getting referred patients. So our next speaker is Dr. Lily Dara, who is an assistant professor of medicine at USC. She is an expert in drug-induced liver injury, and I look forward to her talk.
Hi, everyone. Thank you for inviting me to give this talk today. I'm going to give you an update about hepatotoxicity in general and go get into some specifics. I have no disclosures. So I'm here to talk to you today about drug-induced liver injury because it's an important topic for a bunch of different reasons, not the least of which is the fact that over 50% of all cases of acute liver failure in the US are due to DILI or drug-induced liver injury. And most of these are due to acetaminophen, but after acetaminophen, the most common cause is still drug-induced liver injury of the idiosyncratic nature. This is actually more common than liver failure from acute hepatitis or autoimmune. A lot of drugs cause DILI, and you should be familiar with those. I'm sure many of you attend also on the inpatient service, and this is a common consult. And it is a really important diagnostic and therapeutic challenge. It can mimic all forms of liver disease, both acute and chronic, depending on the drug. So it's tricky to diagnose and you need to rule out a lot of things. And lastly, it has a huge economic impact, especially for the pharmaceutical industry. And it's a big problem for regulatory bodies because they spend billions, millions of dollars developing a drug, and they really don't catch that it's hepatotoxic until it hits the market because the rates are in the hundreds of thousands. So you need to have many, many people using the drug to notice the hepatotoxicity signal. Why is the liver the major target for drugs? For us as gastroenterologists, this is pretty intuitive, but anything that we ingest gets into our liver through the portal system, and hepatocytes pick them up, right? Most drugs go through different phases of metabolism and conjugation. The phase 1 metabolism includes cytochrome P450s. And cytochrome P450s tend to metabolize drugs into toxic metabolites. By toxic, I mean they're reactive and they're electrophilic. So they bind intracellular proteins and thereby elicit an immune response. Think of it as forming a neoantigen. It doesn't occur in everybody though, and I'm going to get to that. Once the drug is metabolized through these different pathways, it is then usually excreted through the bile. Now, when you are dealing with drug-induced liver injury and hepatotoxicity, first, we always know it's a diagnosis of exclusion and we have to rule out other causes. And I'm sure you're all familiar with this. You all do this like in your sleep when you get a consult at the hospital. You ask for the viral hepatitis, you ask for the autoimmune panel. You consider the clinical scenario to see whether you're dealing with a case of shock, CHF, stone disease. But one thing I just want to point out here is something that we sometimes forget to order is an Hcv Rna, because that takes a while for the antibody to mount, right? It takes 10 weeks for the antibody to develop. So ordering an Hcv Rna is key. And for us in Southern California, we're endemic to hepatitis E virus. We actually had a couple of years ago 2 cases back-to-back at county, both from tripe, from a food truck, from a taco. So undercooked pork, game, deer, wild boar, and also seafood can have hepatitis E in it, and hepatitis E IgM and Hcv Rna, even in immunocompetent people who present with acute hepatitis should be considered. Once you rule out in the right setting, once you rule out these major causes and you have the right timeline and a new-ish drug, usually within 6 months, sometimes even over a year, depends on the drug. Each drug has a different signature. Then you're dealing with drug-induced liver injury. So now that you consider that you have a case of DILI, you want to categorize it. Am I dealing with a hepatocellular pattern of DILI or a cholestatic form of DILI? And I like this slide because it really brings to attention a few things. First of all, in general, we define liver injury Usually when the ALT is over 3 times the upper limit of normal. If you have anything below 60, you can monitor it, but 3 is a good cutoff to consider injury. For alk-phos, twice the upper limit of normal. And this could accompany an elevated bilirubin or not. The bilirubin does not tell you whether you're dealing with hepatocellular injury or cholestatic. It can go up in either form of injury. The R value is ALT over its upper limit of normal divided by alkaline phosphatase over its upper limit of normal. For shorthand, I usually use 20 for women, 30 for men for the ALT, and the alk-phos, I usually use the upper limit of normal as 100 just to make it easier for myself. And if that's usually if it's over 5, you're dealing with hepatocellular DILI, and if it's below 2, you're dealing with cholestatic DILI. Anything between 2 to 5 is mixed. And the reason this helps you is that if you go on LiverTox to look up a drug, this is what they use to define hepatocellular and cholestatic. Now, the NIDDK, Jay Hufnagel, who set up this network, and LiverTox, they have reported over the years their database. And over half of the patients that present with DILI in that database present with hepatocellular injury. About a quarter present with cholestatic injury, and about a quarter are mixed. Now, beyond how DILI presents, DILI generally comes in 2 flavors. There's 2 forms: direct hepatotoxins and idiosyncratic hepatotoxins. The direct hepatotoxins are the more intuitive ones. Think acetaminophen, chemotherapeutics. These are predictable drugs. Anybody who takes these drugs beyond a certain dose will get liver toxicity. It occurs to everyone, no exceptions. And generally, these drugs have a short latency. So this occurs within a few hours, a few days of taking, depending on how much of the drug you take. With idiosyncratic drug-induced liver injury, which is the major challenge that I was talking about for regulatory bodies and the pharmaceutical industry, and a lot of the consults we get in the hospital, these are unexpected and unpredictable. They're not dose dependent. They have variable latency depending on the drug you're dealing with. And crucially, this is really important, host factors are very important here. So single nucleotide polymorphisms, age, gender, depending on the drug, really factor into if you're going to get toxicity from it. And the rates are low. So you have 100,000 people or more taking a drug before you can actually start detecting those liver failure cases or these really bad liver injuries. So generally quoted, the number is 17, 19 per 100,000, somewhere between 15 to 20. You can see where the problem comes because no phase 3 trial has that many patients in it. So this is just to show you an example of, this has been studied a lot. There's been a lot of genome-wide association studies by different groups in Europe, by Dylan, in the US, in Latin American groups. Iceland, Bjornsson does a lot of these, basically looking at patients who come in with a toxicity from these drugs. As you know, the anti-TB drugs, INH is a big one. The biggest one, of course, is amoxiclav. And these are associated, when they do genome-wide association studies, they see that people with these genetic mutations are usually more prone to toxicity from these drugs. These are very well studied. And there are some actually polymorphisms that are protective. Some important facts about drug-induced liver injury. So we just talked about this hepatocellular and cholestatic. So the bulk of the reactions are going to present to you with acute hepatitis, cholestasis, or a mixed signature. There are other phenotypes depending on drugs. This can be drug-induced steatohepatitis, think tamoxifen, amiodarone, sinusoidal obstruction syndrome, nodular regenerative hyperplasia, azathioprine, for example, fibrosis, methotrexate, for example, adenomas. You are most familiar with these OCPs, but the bulk of them are going to present with hepatitis or cholestasis. This is key. Acute drug-induced hepatitis with jaundice is very serious. It's life-threatening and has about a 10% mortality. So if you have someone with really high AST, ALT, and their billy's up, that's usually when you want to really contact your transplant center early on. And cholestatic reactions resolve more slowly. They're more indolent. Patients actually tend to do better in the long run. There's less mortality overall, but they resolve very slowly. And there are cases of vanishing bile duct syndrome and secondary biliary cirrhosis, just like you could get with a retained stone, with these cholestatic long duration hepatotoxicities. So who's Hy Zimmerman? Hy Zimmerman is the father of hepatotoxicity and a very astute clinician investigator who observed about 10 to 50% mortality in his patients who came in with DILI and were jaundiced versus those who came in with hepatitis. So viral hepatitis patients recovered, about 1% of them had mortality, but the ones with DILI had around 10% mortality. So these patients were actually presenting with ALTs about anywhere between 10 to 100 times the upper limit of normal, but their alk phos was not that elevated, and their R values were over 5. So, and obviously in the more severe cases, the patients present with coagulopathy and encephalopathy, which, as you all know, is indicative of liver failure. So that's the takeaway. Remember that jaundice with a high ALT is always a bad sign. And this is the top 10 causes of DILI currently. Amoxicillin clavulanate is the single most common agent to cause drug-induced liver injury and is prescribed a lot. If you look on the left side, these are the classes. The antimicrobials are the top class. Obviously, if you all know this from your evolutionary biology, mitochondria were bacteria, right? One cell ate another cell. So it's kind of intuitive that antimicrobials are hepatotoxic. The liver's loaded with mitochondria. The second agent, as you can see here, are still isoniazid, and they're all antibiotics. But second, in terms of class, is herbal and dietary supplements. Big one. And we live in LA, and we have, I mean, I live in LA, you guys live in SoCal, but patients love their herbal supplements. So it's a really common cause of DILI and even liver failure. I'm going to give an update on acetaminophen now, just getting into some specific drugs. So acetaminophen, as you all know, is the quintessential hepatotoxin. We all learn about it in medical school, and as gastroenterologists, we're familiar with it. Its major metabolites are acetaminophen, glucuronide, and sulfate, and those are non-toxic and excreted. But if you take beyond a certain dose, those pathways are saturated, and the acetaminophen is then shunted through the cytochrome P450 system, cytochrome P450 2E1, 2D6, 1A2. A bunch of them metabolize acetaminophen. 2E1 is the big one. And this results in the generation of a toxic metabolite called NAPQI, NAPQI. NAPQI is deactivated by glutathione, if you remember it from your medical school days. And this glutathione is key. It requires an essential amino acid, cysteine. And that's why we give NAC, because NAC provides cysteine to replenish glutathione stores to be able to detoxify and quench all that NAPQI. And this is the typical centrizonal necrosis you see here from acetaminophen. Now, I'm not going to get into the basic science. I just want to show you that NAPQI also targets the mitochondria. What NAPQI does is that it binds protein adducts, forms protein adducts in the cell, causes reactive oxygen species generation, and this amplifies within the mitochondria through this pathway called the MAP kinase pathway, eventually leading to bursting of the mitochondria and cell necrosis. So acetaminophen is also a mitochondrial toxin. Now, this is an older study. I really like it because this actually resulted in the FDA changing their labeling for acetaminophen. So it's from Paul Watkins, Neil Kaplowitz, and them, a group of people published in JAMA. And what they did is they took healthy volunteers, people over 18 that had no disease, and they randomized them into 4 different arms. There's a placebo arm, there's an acetaminophen only arm, and then there's acetaminophen opioid combos. They had a Percocet arm, they had one with Dilaudid and one with morphine, 5 arms. And they gave them the maximum dose of acetaminophen. So everybody was getting 4 grams a day of acetaminophen. Everybody was getting a daily blood draw until day 8, and then every other day after day 8, unless they had an elevated liver enzyme. And importantly, they were provided meals. So everybody was eating the same amount. Nobody was fasting. Nobody was drinking alcohol. So when they gave everybody 4 grams of acetaminophen and drew their blood, guess what? 40% of these healthy volunteers had an ALT over 3 times the upper limit of normal. And about almost 25% of them had an ALT over 5 times the upper limit of normal. And here you can see these ALT graphs. They're pretty high. You can see 600, 500. A lot of them were pretty high. And here, this is one patient 120 is the cutoff. If somebody hit 120, they would stop the acetaminophen and they would kind of, that was, part of their IRB. This patient, for example, stopped acetaminophen here. And as you can see, the circles are the ALT, continues to rise, doesn't come down to under 3 times the upper limit of normal until day 19. So after this, the FDA changed their labeling of acetaminophen. So now the safe dose of acetaminophen in the US is 3 grams. And they actually convinced the pharmaceutical companies that were making these opioid acetaminophen combos to go down from 500 of acetaminophen to 325 of acetaminophen in their combo pills. And an interesting follow-up to that is, again, Jean was talking about Felipe Matherin's group in Lille. It's very interesting. This Lille group is sitting on a gold mine of alcoholic patients, and they've prospectively collected these for a long time. And so this is a study that came out of this group, the group you're familiar with for the Lille model, looking at patients who came to Lille Hospital, Lille University Hospital, with acute liver injury. And they looked at the patients that had acute liver injury from acetaminophen. They took out the cirrhotics and they looked at the non-cirrhotics who had acetaminophen toxicity. And they divided them into 2 groups: 89 patients with acute liver injury at therapeutic doses of acetaminophen, and 311 that came in with the classic overdose story. And I'm just going to show you a busy table, but I want to point out specific things on this table, so just follow me along. So when they looked at the patients who had acute liver injury with therapeutic doses, these were people who in general took less than 6 grams of acetaminophen, and the APAP overdoses always took more than 6 grams. So these were suicide attempts. Of those with the therapeutic acetaminophen, 93% of them were excessive drinkers, as you can see here. It's amazing. And only 35% in the overdose group. And then the duration of acetaminophen intake is important too. These people were drinking alcohol and they took acetaminophen 4 days in a row or more, whereas the overdoses took it in one single ingestion. And when you look at their parameters in terms of their INR rates, their pH, and all their clinical parameters that we look at with acetaminophen toxicity and their ALTs, actually the therapeutic dose group did worse. The alcohol-associated use patients who were excessive drinkers and were taking acetaminophen did worse. And actually 53% of them met the King's College criteria, at least one of the King's College criteria for acetaminophen overdose, versus 30% in the suicide group. Really fascinating. And of those, I told you there was 93% that were using alcohol excessively. This was defined as 80 grams. They were drinking at least 7 drinks a day. Lille is in the north of France. It was a region that was very successful during the Industrial Revolution. I would say kind of like our Midwest, and they drink a lot. There's been economic downturn in that region. And it's also culturally, my husband's from the south of Belgium. So his family lives like 15 minutes from Lille. And I've been to that region, and it's just culturally, there's a lot of drinking. So 7 drinks a day is pretty normal. A lot of these people don't even realize they have alcohol use disorder because it's so culturally ingrained in them. But interestingly, these people, of those, the only ones that weren't drinking alcohol that had liver injury had periods of fasting. And 3 of them actually had eating disorders. So when they looked at, these are all, a lot of things were positive on univariate analysis, but then when they put everything together and looked at a multivariate model, the things that stood out that caused liver injury at therapeutic doses from acetaminophen were older age, the duration of alcohol intake, remember the 4 days, and excessive drinking. These were all independent predictors of disease severity. And periods of fasting, I want to highlight that because we know this from animal models in mice, and we know this from a lot of experience in humans as well, that not eating is associated with toxicity from acetaminophen. And that's why the therapeutic misadventures are so important, because these patients are sick. A lot of times they are febrile and they're taking acetaminophen, they have the flu, and that puts them at risk if they take too much acetaminophen. They also looked at 3 grams, which is the max dose. And even the patients that there was 34 of these 85 had toxicity with less than 3 grams of acetaminophen. And they were also using alcohol and they had the same characteristics. So you don't need to take 6 grams to get toxicity. This can occur at a much lower dose. And here you're looking at 30-day survival in the acetaminophen therapeutic dose group versus the suicide attempts. It was actually lower. So the therapeutic dose group, 87% 1 month survival versus 94% in the suicide. I'm going to switch gears to immune checkpoint inhibitors now. I'm sure you're all seeing this in your practice. I'm sure you see more of the colitis, but hepatitis is a serious matter as well. It's abbreviated immune-mediated liver injury caused by immune checkpoint inhibitors. So we call it ILAC, ILICI. You're familiar with these drugs. Basically, when an antigen-presenting cell presents an antigen, like this little red square here, to a T cell, it can either activate that T cell or it can inhibit that T cell. Usually the activation signal is through the T cell receptor or through CD28, but there's also inhibitory signals. The inhibitory signals that tell the T cell to be quiet is through CTLA4 and PD1, PD1, right? So what cancer cells do is that they upregulate this PD1, these PD1 receptors, and they make, antigens so that they make the T cells quiescent. What immune checkpoint inhibitors do is they prevent T cells from being able to they prevent cancer cells from being able to shut down the T cells. Therefore, they're activators of it. The T cell response, they're activators of the immune response. And due to this, you get collateral damage to other organs, like the skin, like the lungs, like the intestines, and the liver. Here you can see the generic names of the CTLA4s that are approved, and many of these are actually approved for hepatocellular carcinoma as well, or being used off-label for hepatocellular carcinoma. So what do we know about immune-mediated injury from checkpoint inhibitors? The incidence varies depending on what study you look at. It can be as high as 46% in some studies, but I would say it really depends on what drug you look at and how many immune checkpoint inhibitors the patient's taking. Usually it's around 15%. Colitis and diarrhea are very common, actually more common than the hepatitis. But because we're talking about hepatitis, what we really focus on is grade 3 and 4 elevations. These are people who have at least 5 times the upper limit of normal of ALT. So ALT over, depending on if you're thinking of a woman, over 100, over 150, occurs in about 3% of patients, and grade 4 elevations, which is really high, over 20 times the upper limit of normal, in 0.5%. Usually it's a hepatocellular pattern of injury with an R value over 5. So these are usually a high AST ALT, although cholestatic LAC is seen with an elevated alkaline phosphatase as well. We just had a case of nivolumab toxicity, a county with a cholestatic pattern a couple of months ago. So it is seen, but it's less common. Most of the time you're going to see an elevated ALT. And this is important. The latency varies, usually doesn't happen after the first dose. Usually happens after a couple of doses. Median range is between 4 to 16 weeks. Most of these drugs are dosed every 3 weeks. You can't see it after the first dose. I'm just saying in general, it happens 4 to 16 weeks after the second dose usually. And between the drugs, the CTLA4 inhibitors are more potent than the PD1, PD-L1 inhibitors, and that actually there's only one CTLA4 inhibitor, is ipilimumab, and toxicity with ipilimumab is more common. And if somebody is getting dual checkpoint inhibitors, think melanoma patients usually get both PD1 inhibited and CTLA4 inhibited, the risk of toxicity really goes up, like 92% versus 1.7% in one study. And like any form of DILI, you have to rule out the usual suspects. I'm not going to get into this, but you just rule out what we normally do, including the non-hepatotrophic viruses like EBV, CMV, HSV. Fatality is rare. Only 8 out of 20,000 treated patients. And the problem, though, with it is that when you get toxicity, which is grade 3 or 4, this leads to permanent discontinuation of the immune checkpoint inhibitor, as was done in the trials. They have been re-challenges with these. I cannot endorse that because they're not safe and they should be done in a multidisciplinary fashion with consultation with the patient. But the problem is that, when you have melanoma, you don't have that many options. So sometimes oncologists in consultation with hepatologists do decide to reintroduce patients to these checkpoint inhibitors. And about 30% of those patients will again, upon re-challenge, show signs of toxicity. When patients have grade 3 or 4 toxicity, ICIs are held, steroids are given. There are algorithms I'm going to refer you to. If you have a patient like this, look up the algorithm, look up the table. Depending on what the AST, ALT is, it's clearly indicated whether you give 1 gram, 2 grams, IV solumedrol, PO is okay, prednisone. I generally tend to go IV unless it's really mild. And you generally give the steroids until your ALT comes down to at least 3 times the upper limit of normal. And at that point, you continue to taper slowly, like over 4 weeks. This isn't a rapid taper. Median time to normalization is about 20 to 30 days. So it takes a while for the ALT to come down. And the failure rate is low. It's only 4%. But if they do fail, MMF is your mycophenolate mofetil is your go-to, 500 to 1 gram BID. There are case reports of using anti-thymocyte globulin, calcineurin inhibitors, and rituximab, but there is insufficient data, and infliximab should not be used for the liver. There's too much concern for hepatotoxicity with that. So you don't give it, I know we can give it for colitis, but not for hepatitis. Herbal and dietary supplements is my last section that I'm going to cover. It's an increasing problem in the US because herbal and dietary supplements are not regulated like drugs. And there is concerns of adulteration. And also these aren't very well studied. There's a lot of idiosyncratic toxicity from them. They're like DILI, most commonly present with either bland cholestasis or acute hepatitis-like symptoms. There's multiple studies from DILI registries over the years that have looked at the percentage of patients that had herbal supplements in their cohort. And as you can see, for example, Taiwan, 22%, China, 27%, the South Korean cohort, 65%. It's very common, obviously, in Asia. And most of these, as you can see here, present with a hepatocellular pattern of injury. The 2 major groups I want you to remember that you may see in your clinical practice are the young man that presents with jaundice and pruritus, bland cholestasis, usually protracted, rarely fatal, from anabolic steroids. So people who are bodybuilders and are using anabolic steroids. The other major group is the patients who are trying to use weight loss supplements. And the big one is EGCG, which is short for epigallocatechin gallate, which is the product of green tea extract. So I'm not saying green tea drinking is bad. This is very, very high concentrated extract capsules, usually mixed with other things. And a lot of these are proprietary blends. No one knows what's in them, and they're not regulated. So people take these to lose weight and they don't realize how hepatotoxic they can be. As you can see here, this is a slide I got from Jay. Over the years, the proportion of the Dillon registry patients who had herbal dietary supplement toxicity goes up. So it was 5% back in the early 2000s and 15%. And I think in the latest one, it's almost 20% of the database is people who have herbal supplement toxicity. These are the big ones. A lot of these have been pulled off the market, like Hydroxycut. It got pulled off, changed their formulation, and went back in. Slim Quick. Herbalife is big in California. It's big among the Latinx community here. We had a case of Herbalife. We have one in our clinic, a case of Herbalife hepatotoxicity. Just recently, we've had multiple throughout the years. And also one of those proprietary blends, you don't know what is in it, but most of them contain green tea extract as well. So I'm just going to go to the take homes. Number 1, acute hepatocellular jaundice from drugs has a mortality of 10%. So you get a consult, the patient is jaundiced and you suspect DILI. That's a bad sign. That's an early transplant referral. Antibiotics are the leading cause of idiosyncratic DILI. Amoxiclav is number one. Beware, and I didn't have time to get into details of amoxiclav, but amoxiclav can present late. So when the patient comes to you, they may have completed their course for their sinusitis. So you're seeing them 2-3 weeks after they've stopped their co-amoxiclav, right? So I would always ask a history of recent antibiotic use, go back as far as 3 months, tooth infections, headaches, sinusitis, stuff like that. Risk factors for acetaminophen toxicity at therapeutic doses. This is the key here, that you're going to have patients who have therapeutic dose acetaminophen toxicity are excessive drinking, long duration of acetaminophen use. So they had a headache, a tooth infection, arthritis, they were using it 4 days in a row or more, and older age. And fasting is an important risk factor for acetaminophen toxicity. Young woman trying to lose weight has a headache, 4 days, 5 days of acetaminophen use, small BMI, that's a risk factor for getting acetaminophen toxicity. I personally never take more than 2 grams, and I always tell my patients, cirrhotic or not, don't take more than 2 grams. LEC is a rising clinical problem. Risk is higher with 2 immune checkpoint inhibitors. If AST/ALT is over 3 times the upper limit of normal, you get a consult for an immune checkpoint inhibitor. Your oncology colleague refers them. Stop the immune checkpoint inhibitor, close follow-up, plus minus steroids. Look at the algorithm. There's different cutoffs depending on what the AST/ALT and bilirubin are, but most of the time these patients end up getting steroids. And lastly, herbal dietary supplements are important, an important increasing cause of drug-induced liver injury. Beware of the young male who's taking anabolic steroids, will present to you with cholestatic DILI and pruritus. And also be careful with products that have proprietary blends and contain green tea extract, weight loss supplements in particular. And these are the resources. I'm sure you're all familiar with Liver Talks. If you're not, it's a wonderful website. It's curated. There's I'm one of the review editors for it. We find it's from the NIH, every drug. We curate the literature, find all the case reports, and organize it. And then it's free to the public. Fantastic. And then Neil Kaplowitz and Lori DeLev's book. And then that's it. Thank you very much.